Okay, so I think let's go ahead and introduce our first speaker. So I had the privilege of working with her on a few papers over the years, but we've never met in person. And I had the privilege of meeting her in person for the first time yesterday, and she's an absolutely amazing person, and I'm really uh, excited about the talk that she'll be giving today. She already did an amazing talk for us at WITS yesterday afternoon, and I'm sure these will be as good, if not better. So Dr. Orit Kaider is a radiation oncologist and the director of breast radiation oncology at Sheba in Israel. She holds a full clinical position and serves as director of breast cancer radiotherapy uh, and is a senior lecturer at Tel Aviv University. She's an active member of the European Breast Surgical Societies such as Eurobreast and OPBC. She has published more than 150 peer-reviewed papers, several book chapters, and edited 2 radiotherapy books published by Springer. So it's my privilege to introduce Dr. Orit Kaider.
So first of all, thank you. And I would like to thank the steering committee for inviting me, because this is the type of conferences that I'm really excited in participating, because this is a multidisciplinary conference. And this is what we need. This is how we need to practice medicine. We're not a stand-alone expertise radiation. And I'm very excited to visit Parktown yesterday and meet the expert there, and I'm sure we will collaborate in the future. So thank you. So my first talk is about the application of artificial intelligence in optimizing breast radiation therapy. I have no financial disclosures. I am a radiation oncologist. I'm not an AI specialist, but I am involved in AI-based project for radiation therapy in breast cancer. And I would like to say that this presentation was not made by ChatGPT, but I did try. I asked it, can you make a PowerPoint about AI for breast cancer radiation therapy? And this is the reply I got from the chat GPT. So it can't. It did all, but it did make some proposal how to build this presentation. It was really impressive. It took it a few seconds to give me input about the content I should have in my presentation, but I had a completely different thing in mind. So this is not a ChatGPT presentation. So AI is being rapidly incorporated in many domains of our life. The accelerated development is actually a result of different algorithms that were developed through many years. And the most important is the programming capability of those AI systems, such as learning, self-correction, and creativity, which is a human ability. And if I need to roughly divide it into 2 main processes, AI has the ability to have machine learning and deep learning. And we hear it all the time when we speak about AI. So what is it actually? So this is a warning because the next few slides are overly simplified in order for all of us to understand what is AI. We as physicians, as scientists, are used to statistics in our trials. We have the data, we have a sample size that is aimed to represent the whole population. We specify the variables that we want to analyze, and we, prior to doing the statistics, select the appropriate statistical test, like t-test, Kaplan-Meier, and then we perform the analysis, and we have an output for the distribution of probability in a larger population. But when it comes to AI, we need really a lot of different information. The data should not be the same. We need different situation, and the more diverse the data, the better AI. And we don't have predefined tests. The test or the algorithm are shaped and trained over and over again according to the data, according to the output, and being corrected. And this is the process of machine learning. And then we have a general output. And the deep learning is the same process, but much more complex, with a lot of hidden layers of this process of learning. So there is a lot of processes that input and analysis that is going on, aiming to be like the human brain, because we have different level of cognitive. So AI was shown to be successful for different medical indication based on that we have electronic medical data, images, digitalization of different medical application, like we have documentation of skin condition, ECG, digital pathology, so all also for breast cancer, and it's being currently incorporated into clinical practice. And radiation therapy is a modality that is based on technology. We use images such as CT and MRI for planning. We have the treatment planning systems that use algorithms that are based on computer calculation. And the resulting treatment plans are in a format of digital imaging and is used in communication, so we can share those data. So radiation is a natural field to being incorporated in all these AI-based systems. So as a modality, it is based on novel technology. It mandates accuracy in planning and delivery, so it seems like radiation can significantly benefit from the ability of AI. And this is a paper that we wrote in 2020 about what we anticipate that AI will do for our patient and radiation planning. And we wrote the title, "Winter is Over," because for many years there was no progress in the field of AI just because those algorithms were not strong enough. But are we there yet? So can AI assist in decision-making about indication for radiation and the volumes? Currently at practice, we use different tools that are based on nomograms and statistical analysis. I don't know if you use it, like the Memorial Sloan Kettering nomogram, or MD Anderson for DCIS radiation therapy, for if a patient had a positive sentinel lymph node, whether or not, what is the risk for additional lymph nodes involvement. So these nomograms are not based on AI. And this is a paper that evaluated whether ChatGPT can advise in a multidisciplinary meeting, including the indication for radiation therapy. The authors evaluated 10 different cases and indicated that the ChatGPT provided mostly general answers regarding the different treatment modality, but it was not able to provide specific recommendation for therapy. So at this moment, we don't have very good tools to replace our multidisciplinary. And how about AI, if it can assist in shared decision with the patient, because we have a lot of different, for example, surgery for the same clinical stage of a breast cancer, and it might end up with different aesthetic results for the patient, whether oncoplastic or just breast conserving therapy, or whether or not reconstruction. And many of our patients get their information from social media and unsupervised websites that are subjected to misinformation. So this is a project that Sheba and my department is part of it. It's called the Cinderella Consortium. It is supported by Horizon, the EU. And we're developing a tool, an app for patients that is evidence-based to assist in a shared decision process for local regional therapies, for surgery and for radiation. The app is aimed to provide evidence-based data at the level of the patient and also predict and visualize to the patient how her breast will look after treatment, if she's having an oncoplastic surgery, if she's having breast reconstruction and radiation. And this is based on patient own body habitus and breast. We are photographing the breasts, and the app will produce a visual output for the patient to assist in the decision if she have a few options for surgery. And can AI assist in the process of delineation? I mean, part of our job is to delineate the organs at risk, the heart and the lungs, for example, and the target volumes for breast. And this might change for different patients. Some patients will need only breast irradiation. Some will need also a boost to a tumor bed or different lymph node levels to be delineated. So currently there are several systems available for automatic delineation for target volumes and organs at risk. Some are based on prior knowledge, which means are not AI-based, but are based on large databases for delineation. There are AI models for automatic delineation of organs at risk and target volumes, which are different systems are based on different means. Some include prior knowledge. It means that it is based on prior delineation, and others are based on statistical models of shape of appearance, and et cetera, et cetera. So different systems are based on different ways of development. And those systems have different performance abilities. And when you look at what is published out there, the studies that are evaluating those systems, there are very few studies, not a lot. So this is interesting because we're incorporating a system into clinical use without studies. We need to see what we're doing. This is not really good. But those who are evaluating those systems are basing the recommendation on the need for edits, dose delineation, the output time, the time needed for edits, and certain methods to evaluate the differences between two volumes. For example, the DICE, which is a similarity coefficient method evaluation, or the Hadroof metrics, which is another method to evaluate the difference between two volumes. And those studies report that the new AI system overall needed minor edits and were extremely time efficient. So I was so happy to read those because this solves our problem at clinic, because we will have time for coffee, right? And when you look, these are the main leading system, the RPA, which is actually an initiative by MD Anderson to assist in delineation and reduce the workload, mainly in low and middle income countries, based on the MD Anderson specialist. The indication there is post-mastectomy radiation. The system aimed to allow for auto-delineation and planning. This I was a little bit, the publication need not say what does it mean with regards to target volume, which nodal volumes are they speaking of. It aims to assist in delineation of the chest wall and organs at risk. And the publication indicated that 50% of this delineation were accepted as is, and the other 50% needed minor edits. The time that it took for the whole process was reduced compared to manual delineation. The other system is race station system, and it was compared to two non-NI auto-segmentation program. It's including post-mastectomy and breast, and in the publication it indicated the level of lymph nodes that this system is able to assist. And again, and here it's even 92% was clinically acceptable with minor edits, and again, overall time reduced mainly for organs at risk. But, and I usually have a but, when I present, I am a member of the URTC quality assurance team. And when I compare how we evaluate those delineation for trials, we don't really use only DICE on or those metric evaluation or time. We also judge the delineation according to minor and major violation of protocol with regards to clinical significance, because you can have 1 millimeter out of your target volume, but into an organ at risk that can significantly change. So after reviewing those data, the publication, unfortunately, I was very disappointed about all those studies evaluating the delineation systems, because for me as a reader, it was missing the most important information. And therefore, I think that if we use those AI, we need to educate the young generation and make sure that they know which edits to do and not only rely on AI. And this is our experience. When you want to purchase such a system, many of the companies will give you 1 month free use to evaluate the system. So please use this, ask for this, because this is, I won't reveal the name of the system, but this is an example when we assess this, the system. This is a snapshot of the delineation we got. So it looks great. It looks much better than my shaky hand when I delineate. But when you look at the volumes, and no laser, okay. When you look at the tiny orange arrow over there, and you look at the breast limit, it is over estro recommendation for breast volume. So it's a few millimeters, and you can grade it as a minor edit. Really, it's unimportant. And for the other area, the system delineate the abdominal wall because you have the inframammary fold. This is really minor edit. It's less than 1 minute to correct. But if your colleague put the tangential fields on this one, you might irradiate the GI system, which is not necessary, and you might irradiate the heart. So please, don't rely only on AI. You need the basic knowledge. And again, this is an example for the lymph node level. Level 1, I don't know if you can see clearly. This is not level 1, this tiny yellow dot. level 4. This is too high for level 4 and obviously does not include all the fat around where the lymph nodes are. And you might irradiate and cause here mucositis and hypothyroid because this is too high for level 4. And obviously, this does not include all level 2. So this is snapshots of the systems we evaluated, and we decided not to percush until they improve. And even human have differences in delineation. And this is a snapshot of the course at Falcon that we're doing. And you can see the delineations of the students. And most of our students are professionals, are experts. It's not only residents. They just want to refresh and practice their knowledge. And this is an example for what happens if you have a too large breast volume. You will not maintain the constraints, and you will include the heart in your tangential. And by the way, as we spoke Duvern yesterday, we are looking for tutors for Falcon, so please email me if you have any residents. It's a great way to practice and learn. So, and another thing in that system is when we look if the system can assist in planning, in doing the calculation and providing a treatment plan. So the RPA indicated that they have the ability to plan, and in the publication, they mentioned that the volumes of the nodes are a suprafield, which we no longer speak in fields for radiation breast cancer. We speak in volumes. What is suprafield? Is it only level 4? Is it level 3 and 4? I don't have a clue. So, and this is an example why we need to stop speaking in fields. This is a publication that we published. This is an example of a 2D suprafield. And you can see here the dose where it covers level 4 and a little bit of level 3 of the breast of a patient that had complete axial lymph node dissection with 22 lymph node excised in the axial lymph node dissection. So really, there is no indication to include the operated axilla in this treatment. But the patient recurred many years after, but as you can see here in the PET CT of the recurrence, she recurred at the area that was not dissected in the axillary lymph node dissection. So you can't define breast radiation according to fields. You need to decide on your treatment volumes according to each case. If level 2 was not operated on, you need to include level 2 in your radiation. Otherwise, we're not doing anything. And other systems that can assist in radiation planning are the Ray Station, as I indicated, and overall the publication indicated that the time needed for planning is reduced. EasyFluence also is field in field base, and the time is reduced. We actually used this for a while in my center, and we were very happy with EasyFluence for assisting in planning, although you still need to supervise the program, because sometimes for the radiation oncologist here, it uses too many fields in fields. So too many tiny fields, which the treatment is very long, it's inefficient. So it does help, but we still need human knowledge. And there are so many training programs online. If your residents are part of members of ESTRO, they can use this video that we produced just to learn how to delineate, because you need to supervise those systems. So, can AI assist in quality assurance of radiation therapy? We have many publications that radiation quality assurance in clinical trials matter not only for toxicity, but can reduce significantly morbidity and mortality, disease outcome, including in breast cancer. And trials that had centralized quality assurance showed major deviation. That's a problem in third cases. And think, who are those centers that are participating in randomized control trials? These are usually the well-supported centers, the centers that have financial support and abilities and infrastructure to participate in those trials, and they have third of the cases have major deviation. So we need quality assurance. Assuming, as I indicated, that those sites even have less workload than most of us. So this is quite alerting. And this is just an example for head and neck. What is the importance of quality assurance? And in this publication, they indicated, and they nicely show in this graph, that centers that were compliant with the protocol had better local regional control compared to centers that were either non-compliant or have major deviation. And what gives us some hope that centers that corrected and improved during the trial did better eventually. And this is survival, and this is quite alerting. Again, centers that were compliant with quality assurance and with the protocol, the survival of the patients was better. So, and how about breast cancer? I mean, we always make jokes that breast cancer radiation is not head and neck, but for breast cancer, the proximity of the breast and chest wall and the regional nodes to the heart and to the lung and sometimes to the esophagus and mucosa can lead to significant toxicity to the patients, and we see it. And it mandates understanding and meticulous planning and delivery of the radiation. And for some breast cancer patient, the indication for radiation and the therapeutic window is so marginal that if we make a mistake, we lose the advantage of treatment. And that is why we don't have any range for errors in treating those patients, because these patients are curative, and we need to do an effort for that. And we have evidence for that. The trials that had central quality assurance were the pioneers in showing that the breast cancer radiation, for example, for internal mammary, improved survival with limited toxicity. And the EBCTCG new report, which in the Lancet, not Lancet Oncology, even now divided modern radiation therapy from 1989 to older trials, and showed that older trials did not show a benefit and modern radiation does provide a benefit. And this is all because of planning and quality assurance. And this is an example that we published recently from the URTC internal mammary trial, and we proved here that techniques matters for outcome, for toxicity, and breast disease outcome. And when you use a bony landmark-based technique, you barely have a benefit from radiation. But if you individualize radiation therapy for those patients, and you take into account body habitus, etc., you will have a benefit. How about, so we are discussing quality assurance, so can AI assist in quality assurance? Yes, there are now systems that aim to assist quality assurance in radiation therapy. And when you give a presentation, you always need to have some sort of figure that nobody will understand while watching it. But I will summarize from the publication that I like that sentence actually, that the successful clinical use of any AI-based application relies on an accompanying workflow of quality assurance tools to verify the suitability of AI output on a case-specific routine basis. So we cannot replace human input. We need to supervise that the system, and since this is so complicated, it will become more complicated for our medical physicists and colleagues to understand where the system was wrong and how to improve it. So what are the future for AI optimization of breast radiation therapy? I indicated before about the Cinderella project. So what is special about the Cinderella project, that as opposed to many systems that are incorporated into our clinical use, that are not evaluated in a prospective clinical trial or just evaluated in retrospective studies or cohort, this app is actually being evaluated in a prospective randomized trial. And this is a very complicated design because the app and the AI is gonna improve ongoing during the trial that we're doing according to the output. So it's very, for me, I'm used to simple randomization, but the app is going to improve according to the feedback we're giving during the trial. So this is, I would say, an evidence-based app going to be, and now one of the site is already starting to recruit patients. It's Lisbon, and hopefully the rest of, we're 5 clinical sites, so we hope to start recruitment soon. And this is how we're doing it. We have a photo robot that is photographing the patients in the same position with the same light and at the nipple level. So we have everything very precise. Then the system is supposed to give an output according to the patient body habitus, size of the breast, and according to the type of surgery. And it will produce to the patient a picture that if she has a good aesthetic outcome, this is probably how her breast will look. And it indicates to the patient, it might be that you will have a poor outcome, and this is an example of a poor aesthetic outcome. This is because many of our patients, we're very happy with the surgery and with the oncological outcome of the surgery, that they have negative margins, everything went well. But then the patient look at their breast and say, I'm not happy, I cannot live with this, please correct this, please correct, can I do another surgery? And so we want to give them an insight how the breast will look, and hopefully it will be a shared decision and a better understanding for the patients about the procedures. Another project that we are involved in, actually it's initiated by us and supported by ASCO, is an AI tool to delineate the target volumes based on MRI after immediate breast reconstruction on an implant based. We know that we have residual breast tissue. I will speak in my next presentation about that. And this AI system, since in Israel we're performing MRIs after immediate reconstruction, this system will help in identifying the high regions for recurrence. We're not there yet, and we discussed yesterday in Parktown the difficulties nowadays in planning a tumor bed boost, because it's very difficult with all new surgeries and clipping to identify where is the area that we need to boost. So unfortunately, none of the system currently available is assisting us now with this delineation. So I would summarize that radiation as a treatment modality rely on novel technology, and as indicated, it mandates accuracy in planning and delivery. So it can significantly benefit from the ability of AI. However, and this is very important, the performance of the system will be outstanding if the process is outstanding. So if we have good data and we supervise and we correct it, it will be okay. The quality of data that we provide the system is important. The quality of reviewing and correcting and training of the system is important. The ground truth, which is the human that is providing the data and correcting, should be outstanding. And the user of those AI systems should be outstanding and have the ability to be critical about the output. The AI will not replace us. It will challenge us to be better, because it will be difficult to know where it went wrong and how to correct. So we shouldn't rely on it blindly. Radiation delineation and plan evaluation are usually performed according to recommendation of treatment and objectives and constraint, but it's not similar to all patients. In some patients, you will compromise just to reduce the hard dose, for example. And even then, it significantly varies between different experts. And it's not only a measure of quantitative measures like dose max, but as I indicated, it changes according to different patients and the risks they have. Tumor response and toxicity can be significantly different between patients. And let's not forget the patients. They might want a different approach due to their culture, their views, their personalities. So we need a shared decision. AI cannot replace it. So it's very nice, and I'm sure it will have a significant role, but it will not replace human expertise. And we need to remember, so it will mandate us to improve our knowledge and expertise and challenge us in error prediction, because it is a sophisticated system. And we need to remember that we are the ones who made the oath for the patient not to harm, not the AI system. So it is our responsibility to make sure that when we use it, no harm is done to the patients. So I would like to thank you for listening and inviting me. Duvern, I'm very grateful, and I have Sudeshian as a new collaborator in a book chapter that we're writing together. And thank you so much. I feel like I have new friends now, so I'm very happy. Thank you.
Thank you very much, Orit, for that fabulous presentation. I think you've really clarified an area. I think that's becoming more and more important. But I think a lot of us don't understand properly and are trying to sort of grasp how that will affect our practice going forward. We have a few questions online, so maybe we can take them, and then we can take a few from the audience as well before our next speaker. So the first question online is from Dr. Nyakabao from the University of Zimbabwe, and she's asked, I think something that we've talked a little bit about. What is the impact on the use of AI in radiotherapy and the cost of radiotherapy? So I think she means the access to radiotherapy and cost.
So, Duvern, I think you're more into it now compared to me, because you're involved in a very important project with Varian, right? So
Yeah. Yeah, absolutely. So, yeah, my feeling is that, the major benefit of AI is going to be in the developing world where there is a lack of skills. And AI can really play a major role in bridging that gap. And in terms of access, will allow treatments which weren't available in many parts of the world to start to become available there because it'll provide the skills. And I think in terms of costing, I don't think there's a lot of studies as to what the cost would be, but the way it's being touted by the big tech companies that it will eventually drive down cost. There's a lot of other issues around that. Should these tech companies compensate the experts who developed whose intellectual capital was used to develop those systems? Should they be compensated for all the output that AI produces in the future? So there's a lot of issues around that. But I think in terms of cost, it probably will drive down cost, and increase access in the future. But what's your feelings, Oren?
I think we should pressure those companies in making sure that first human resources are not harmed by these developments, and we can do that as users. And also, they will need our expertise in improving those systems. So us as a resource is needed, and this way we can pressure them also. I do think it will benefit us because if it will reduce the time that we need to plan those patients and will allow for a new patient to be treated, eventually it will become cost effective. But we need to really stand out for ourselves.
Yeah, absolutely. Perhaps we'll do the other one that's online, then we'll take a few from the audience. The second one is from Dr. Done Ness, and she's asked, has medical malpractice cover underwriters matched the development and incorporation of AI into medicine yet?
Wow, that's a smart question. I think let's let the US people that are really exposed to all those insurance issues deal with that.
Yeah.
But I think if you're a user of those AI, then you take responsibility for the mistakes because you need to supervise the system.
Yeah, I think in all access, I agree with you. I think the legislation has not kept pace with AI and its developments. The technology is just developing at such a fast rate now, and I think we're going to have to answer those questions around malpractice, etc. There's a lot of like I mentioned earlier around compensation, etc. I think also needs to be addressed. So yeah, I think absolutely it hasn't kept pace at all. I think we can now go ahead and take from the audience. Yes.
I wonder, with all developments in AI are not limited only to medicine, but particularly in radiation oncology. The systems are trained on historical data. That also means that historical data are being perpetuated and historical errors are being perpetuated. How do new data find their way into these systems? How does new evidence become integrated?
So this is an important question, and we know that we have in different areas of our life, AI can be biased due to historical data. So we had even in the news in Israel to show that in Israel some of the banks are using AI to decide whether to give the clients a loan or not for a mortgage loan, for example. And they entered the same information. The only thing that was changed was male and female. So obviously the female was not approved for the loan due to historical data that female are less successful at work, maybe earning less, etc., etc. So you're absolutely correct. So this is why we hope that by incorporating deep learning and making this process, it's not only about the AI now in radiation, it's not only on prior knowledge, on prior delineation, but also a system that has, they say it's a hidden layer of algorithm and analysis. And we need to be there in the process to correct the process and make sure that it doesn't make biases and historical errors. So you're completely correct.
I think we'll take one more from the audience. Sudeshan, yeah.
Thanks, Audit, for that overview. Just two comments. I totally agree with the difference between deep learning and machine learning and using expertise from that way. What are your thoughts on AI basis from or AI bias from radiation oncology? So we mentioned that there are different contouring companies, some that are commercial and some that are open source. The RPA done by MD Anderson is an open source tool by Lawrence Court, and the rest of them are by commercial companies. In private practice, we find that the commercial companies really won't tell their clinicians what their qualitative and quantitative metrics are. And hence, clinicians are informed incorrectly on how to actually use AI in their routine practice.
That's a huge problem, and I fully agree with you. There is no visibility in some of the things that it's not only the commercial, but yeah. And we do have differences between the Estro and Astro atlases. We do have differences between different expert delineating. Even in Estro faculty, we sometimes disagree. So yeah, we still have a lot to do before we can just take the AI output and say that's great, let's use it in clinic.
So I agree in terms of there should be more clinical trials with experts validating this data against ground truth in a cross-fall validation method.
Yeah, but I emphasize in my talk that you need to know what is the ground truth, because for someone that is delineating according to Estro guidelines will not accept probably a ground truth for someone delineating according to the RTOG guidelines. So we have many challenges before us before we can blindly use those systems.
Thanks, sir.